Welcome to this discussion of the medical management of COVID-19. I'm Mike Tevald. Our objectives here are really to just review current trends in the medical management of COVID. This is a rapidly evolving field. There's not much evidence, so we're just going to do a brief overview of some of the major players. The big take-home message: there is no FDA-approved product to treat COVID-19, and there is no vaccine for COVID-19. That could be a very short, this could be a very short presentation, but we are going to talk about some candidate drugs. The current standard for management of COVID-19 is really self-isolation, self-monitoring, and symptom management. So people who test positive it's recommended that they isolate for 7 days and greater than 3 days after symptoms resolve without taking medications that might mask those symptoms. If there's a household exposure, if someone living in your home has tested positive, then you are supposed to self-isolate for 14 days. Self-monitoring: most of the people that test positive for this virus are either asymptomatic or have a mild form of the disease. So really just monitoring your own symptoms and seeing if they worsen, then to seek additional medical help. Symptom management, focusing on supportive care, so antipyretics are really kind of a mainstay. Certainly taking fluids and just kind of the resting and taking care of yourself is the mainstay of treatment for most people. Now, about 20% of these people will have a moderate or severe form of COVID, and for those they might develop hypoxemia and need supplemental oxygen, and the presentation can get severe enough that people need mechanical ventilation and other forms of life support. So for those people, that's where most of the research on medications has been focused. Here's just a diagram from a recent review showing the life cycle of the SARS-CoV-2 virus. So we see this COVID-2 virus binding to this ACE2 receptor. So ACE2 stands for angiotensin converting enzyme 2 receptor. So this is related to the angiotensin aldosterone axis that we talk about with hypertension. And people who take ACE inhibitors or angiotensin receptor blockers have an increased expression of these ACE2 receptors. And there's the theoretical risk that people who take these medications may be at higher risk of developing, of testing positive for the virus, or might have a worse outcome. Turns out the evidence to date does not support that, and the American Cardiology Association, American Heart Association, all recommend that people who are currently taking ACE inhibitors or angiotensin receptor blockers continue to take them. We do not have any evidence at this point that, and actually we have very limited, but some evidence to suggest that there's no difference. Taking those drugs don't affect the outcome of this virus. So once the virus binds to that ACE2 receptor, it goes into the cell through endocytosis, and then we have translation of RNA and the building of new protein, and then we have the assembly of a new virus, and we have the virus leaving that cell, and that's called virus shedding. This illustration shows the different points where some of the different drugs might have their biggest action. So chloroquine and hydroxychloroquine, which was kind of the biggest talk early on, inhibits the entry of the virus into the cell. So that is one mechanism of action whereby hydroxychloroquine may have an effect on the COVID virus. The other kind of major player in the antiviral area is remdesivir, and this prevents this step here, RNA-dependent RNA polymerase. So it prevents the polymerization of RNA and the eventual building of new proteins and new viruses. So those two would be considered antivirals because they will actually prevent the replication of the virus itself. Another drug that you may have heard about is tocilizumab. This is an IL6 receptor blocker. So IL6 is an inflammatory cytokine, and there are a certain portion of these patients who develop, who are positive for COVID-19, develop what we call hyperinflammation or cytokine storm. And IL6 appears to be involved in that. And these drugs are immune modulators. So they basically manipulate the signals of the immune system in order to prevent that hyperinflammation. And in people who have the most severe form of the disease, it's really that hyperinflammation that is causing significant damage. So this is another category of drug that is under investigation. So here's a schematic of the disease course or potential disease course, and this comes from the Hopkins, Johns Hopkins. Here's the link right here. It's an excellent resource if you're interested in medical management of COVID. They also have epidemiologicals and stuff, so they have just a fantastic set of resources. This red line is the actual SARS-CoV RNA, so this is the viral load, and this is the day since the symptom onset. Now, symptoms start with fever, cough, myalgia, and dyspnea. In some people, they develop hypoxia, respiratory failure, fever, and hypotension. And some people go on to develop acute respiratory distress syndrome. Some of those people recover, many of those people die, but this just shows a potential course of the disease. It also shows some different categories of medications and where they might be helpful. So we talked about antivirals, hydroxychloroquine and remdesivir. We'll talk a little bit more about those two. Those are the antivirals, and they're going to be much more effective in the early days of the virus because their job is to prevent the replication of that virus. Convalescent plasma is going to act through a different mechanism, but that's also going to be most effective in the early days where it can really fight the virus itself. And then the immune modulators are going to be effective a little bit later on, and only for those people who are showing that hyperinflammation, that cytokine storm. So let's talk a little bit about, and we'll talk about basically 4 drugs: hydroxychloroquine, remdesivir, convalescent plasmid, and tocilizumab. So hydroxychloroquine, this got a lot of press very early on. It is an anti-malarial drug. It has been around for a while for the treatment of malaria and also rheumatoid arthritis. So we thought we had a pretty good handle on the risk profile. It does have anti-COVID activity in vitro. However, that is really just the ground floor. That's the absolute minimum. There are so many drugs that show antiviral activity in vitro that don't actually work in humans. So really, that is kind of the price of admission in order to be tested for effectiveness, but that does not guarantee effectiveness in humans. Hydroxychloroquine is available through clinical trials. There are many clinical trials going on here in Europe, in China, and other parts of the world. It's also available via an FDA emergency use authorization. So hydroxychloroquine is it's FDA approved for the treatment of malaria. But what the FDA emergency use authorization did is it increased the availability. So the federal government has a stockpile of hydroxychloroquine that became available for use in certain COVID patients, severe and high-risk cases. So that was issued in March, the end of March. Now, more recent evidence has come out, and the FDA has kind of modified that and cautions against the use of hydroxychloroquine outside of a clinical trial or the hospital setting. So what are the effects in humans? The evidence for effectiveness in humans is very weak, actually. The initial study that was published that I think led to a lot of the excitement about this drug was a case series, but it was very limited in its design. And since then, some other studies, including RCTs, have been published both in France and in China that have not shown effectiveness. In addition to that lack of clear evidence for effectiveness, several studies have shown higher risk of death. So there was a Brazilian randomized controlled trial that was ended early because of increased risk of death in people taking hydroxychloroquine. There was a retrospective analysis, which is not a controlled study, but there was a retrospective analysis of VA, people in the VA system, that suggested that the risk of death was twice in people taking hydroxychloroquine compared to people who were not. Now, that's an observational study that we are randomly assigned, so it's difficult to draw conclusions from that. But there is a known risk of arrhythmias, specifically long QT syndrome, and also cardiotoxicity. There's also a risk of hypoglycemia. There are some side effects associated with hydroxychloroquine: headache, dizziness, tinnitus, nausea, and vomiting, and abdominal pain. Right now, it seems that the safest bet is if hydroxychloroquine is going to be used at all, that it be used in a carefully controlled and monitored setting where we can have ECG monitoring to monitor for arrhythmias and long QT syndrome. As of yet, there's no published evidence to support its use as a prophylaxis, although studies are underway. Remdesivir, so this is another antiviral. So this is available through clinical trials. Also, there was a recent, May 1st, the FDA released an emergency use authorization for hospitalized patients with severe COVID-19. So severe meaning either they were on mechanical ventilation or ECMO, or they have oxygen saturation below 94% on room air. It does have anti-COVID activity in vitro. It has also shown effectiveness against similar viruses in humans and in animal models, including Ebola, MERS, and the SARS-1. There have been a couple of clinical trials that have come out. There was an industry-sponsored trial that there was a press release. It hasn't been published yet, to my knowledge, but there was a press release that showed there was no difference in effectiveness between people getting a 5-day dosing of the drug and a 10-day dosing of the drug. There was no control, so it's difficult to draw conclusions about effectiveness. There was a randomized controlled trial from China that showed no difference in the time to clinical improvement in people who received remdesivir versus the placebo. There were some significant limitations in that trial in terms of when people received the drug in that course. Remember, these antivirals should be most effective early on, and some of the people taking the drug, were in the later phases, and some of them were no longer shedding virus. So there's some limitations in that study. There was an NIH-sponsored study trial, and again, this is from a press release. The study hasn't been published yet. That showed 31% faster time to recovery. So based on largely on that NIH-sponsored trial, the FDA did release that emergency use authorization. We need to wait for the final results of these studies and additional studies that are underway in order to really understand what patients this is going to be useful for and when in the disease course it might be helpful. So those are the two antivirals that have received the most attention. This is a convalescent plasma. So this is where people who have had COVID-19, have been positive and have survived, can donate their blood, and we can try to isolate the antibodies from that blood and then give it to people who are diseased. So this is a passive immunity. So we are harvesting antibodies from one group of people and giving them to another group of people. This idea has been around for a long time, and there are some case series and some anecdotal evidence suggesting that this may be safe and it may be effective. It's currently limited by the supply of the convalescent plasma, which is available through clinical trials, and there are also ways that hospitals can work with blood banks to try to get some convalescent plasma. So like I said, this technique has been around for a while. Sometimes it's been successful, sometimes it hasn't. We don't have the evidence as of yet, but that is another strategy that is under study. Tocilizumab, again, this is that antibody against IL6. So it's a monoclonal antibody. So it's an antibody from a single line of plasma cells, of beta cell, of immune cells. So it blocks the activation of IL6, which is that pro-inflammatory signal. And the theoretical hope is that it will block that hyperinflammation, that cytokine storm. We do have some anecdotal reports of rapid clinical improvement, so there's a lot of excitement about that. But again, very limited hard evidence as of that. So there are several trials underway of this strategy. Finally, conclusion. Again, no drug has proven efficacy. Clinical trials are ongoing, so you should stay tuned. Here are a couple of references, including this Johns Hopkins Medical Institute clinical guidance. I think that is probably the most useful of all the references that I've included.